Debbie.
Hello, everyone.
And is Ash Schradecker. And they have before the I'd like to introduce a little bit about our two fellows. Dr. is an anesthesiologist, finished in Western Ontario, and decided to come to do a pain fellowship with us. And we're excited that we have FRCP to one of the pain fellows. He's been doing remarkably well. I'm very sure that he'll do well in his future career in treatment and anesthesiologist. His topic is chronic pain management in Ehler Danlos syndrome, which is very interesting. Dr. Schradecker, she is anesthesiologist and also emergency as well, and she finished training in as well as Switzerland. And last year, I come to Hamilton, the family, to do a pain fellowship. You're going to see one more year on a research relation. She received a grant for relation chronic pain management, and this is actually her topic. Without further ado, I'm going to we already start, but now I have to introduce. This is the second month that we are starting WebEx presentation. I'm very excited that a lot of people are joining, and at least at this point we have 4 or 5 participants, and I just thank you for participating, and we have a chance to and answer just possible. So
thank you so much for braving the weather to come see our presentations today. Really appreciate it. So without further ado, I'll just start my presentation. So the topic that I picked was management of chronic pain in patients with Ehler Danlos patients. And so the reason I picked topic is that recently, over the last 3 months, I've been on a rotation which is our campus. I saw 3 patients with Ehler Danlos and with different staff. And for medical consultation, we just each look at each other and be like, I diagnosed this, but I know nothing about chronic pain Danlos. And if some very reasoned staff have in their knowledge, I figured a lot of it as well. So I thought it would be an interesting topic to cover. It's also interesting because it sort of enhances care from pretty much many different healthcare professionals within our disciplinary teams, something that is a huge focus here at McMaster, as it should be. So what are syndromes? So they're a collection of tissue disorders that are very varied in the type of impacts and what ends up causing them with genetic mutations. There's many different genes. We won't go into all that. We'll leave that to rheumatology. But it's connected to disorder, and it has 3 basic features to it. One is that these patients have very hypermobile joints, stick, and also very poor wound healing. And the other thing is it affects men and women of every race and ethnicity. Slightly more, anecdotally more commonly in females, and a lot so early on in their life. So one connective tissue is part of the matrix. This is what's keeping all of us together, apart from all the other blood, everything else that we have. This holds us together. And specifically, that deals with collagen, which is pretty much present all the way to your skin vessels, to your organs. This is what the resisting change body. Without collagen, we would mold and elastic. That's a superpower, sure, but that's not what we're going for on a regular basis. But collagen, when it has increased elasticity, it can cause a lot of issues, which is what sort of base of pathophysiology of chronic pain in Danlos is. Silence in itself, beauty during this presentation was that only recent in March of 2017, the American Journal of Genetics met. There was a huge subcommittee, and they pretty much overhauls the whole Ehler Danlos classifications, literature review. So all the information here is actually from 2 months ago. Up until 2 months, there were 6 subjects. Now there are 13. No Ontario. The certain report that was the Ministry of Health. And 1 in 5,000 are the odds of people living with illness, so it's technically classified as a rare disorder. And the other, there's a lot of overlap with hypermobility spectrum. There's out there where you can see hypermobility. None of them are Ehler Danlos. That's semantics, and this is an issue that a lot of specialists run to. So there are 13 sites, one, two, which is that we see quite a bit of, is hypermobile EDS. Together, they form 5% of all those patients. And usually, the pain starts in the 2nd to 4th decade. So, from the report that was drafted for the Ministry of Health, are estimated approximately 27 people in Ontario are affected by Ehler Danlos syndrome, and specifically within the Hamilton Niagara region, there's about 287 people that have this, and a lot of surrounding areas. So it's not something you won't see. Recently, I was talking to my colleagues here at McMaster Clinic, and they saw 3 patients themselves the last few months. So it's sort of like general description of hypermobile joints, and I'm sure we all know someone who can do this to win bar bets or to impress you. So it doesn't mean they have Ehler Danlos, but this is a bit of a representation of hypermobile joints. Also, grading, but others not ideal. And chronic we're here to discuss. So, prevalence of chronic pain issues in these patients has been classified as 90%. And what's very important for health professionals here is that it actually can be the presenting symptom of this illness. So, for healthcare professionals to recognize that, oh, this person has pain, they have all other issues. So I'm speaking to the clinic Toronto, which is a specialized virtual theater. It's the only Ehler Danlos area now. They get 80% of the referrals from chronic pain programs. They do get it from the doctors. They get a chronic pain program. I'm not really sure how many people have referred to a specialist program for Ehler Danlos. I've never done that. So issues that you recruit pain is children. There's been a difficult feature chronic pain in pediatric patients. I told you one female shows up with widespread body pain, most of right off the fibromyalgia, right? Other common misconception chronic pain in this illness. And most will see it localized to insulin. And review that was done in March, and as you see, generally is in 90% of the patient, joint pain, shoulders. I'm not really sure you can see well. And the feet aren't affected. Actually, one of the distressing issues that is seen, very high incidence of neuropathic pain, about 70%. The other two is loss of proprioception. We'll go to. So it's actually written as significant p-value. It's among all my, it's actually listed as one of the most chronic issues that exists with Ehler Danlos patients. Among you also have headaches, a lot of GI pain, TMJ pain, a lot of issues. So benign system can be affected, which also adds to the complexity of diagnosis. Process of where our joints in the whole spectrum. We have receptors all throughout in our skin and in our joints that feed to our brain. Where my hands and far, this is where they need to be. It's essential for maintaining your balance, for detecting and coordinating movements. And so it sort of tells you that, you know what, you're at the extreme of your motion. You push it any further, you'll damage the joint, right? These lack. So that's why they go around extending their hands, feet, joints beyond they should be. There's damage to that. So perception have been shown actually improve pain. So, the perception, your joints are all over the place, you're damaging them. You improve perception, you can actually help reduce them. And a very common report that you will see patients that who may or may not have Ehler Danlos but have all these issues is a get klutzy. You'll be picking a lot of stuff that's related to precision. So this is more people who do therapy, physiotherapy, jumping, balance board, setting, exercise ball. Hydrotherapy is a very commonly utilized technique because it's quite points. The recommendation is not to swim, but to tread or walk in the water or ending up on a paddle board. These are just examples. The first ones that we extend the paddling paddle and the treading in water. The other interesting strategy to help with perception of thinking about is something called kinesio taping. So it's basically a tape with elastic adhesive you can apply to a person's skin, and it acts the superficial layer of the skin. As these skin damage its elastic, adding a super layer of skin by adding this tape allowed to be played past tried very strict pattern. I what that is because it gets pretty complicated. But you need training for and I went to the physiotherapy school at more. It's very rare that they cover it for maybe more than 10 minutes of the whole program. So it's not something a lot of people know about even physiotherapy. So there's specific courses out there that people are interested. So the mechanism that people that this tape helps them with that it can by applying the tape you're actually stimulating the mechanoreceptors with any kind of touch. As I already said by physiotherapy, and it stimulates the sense of the skin. Once again, it's not entirely evidence-based based on my reading, but once again, from what people who work with this feel that this adds a lot of benefit to their patients. This piece of tape looks like it's sort of in a pattern. It mimics the exact, but so are by improved movement patterns, it relax muscles, size the joints. If your bone is weak and you're applying taping and putting it some kind of a structure, it sustains the joint. And any of your weak joints in your body, like shoulders, them can help. Has been shown to reduce swelling in these patients as well. This is what taping of the knee looks like. For the you can much anything. We were talking about is the TMJ pain, which is present in approximately 6% of these people, and it's difficulty getting out, king of the jaw, headache for neck pain, a lot of trigger points. So it's not TMJ. If any of you've had it, it's actually quite painful. So treat very conservative, avoid very consciously to not excessively open your mouth. Caution: they need to see an orthodontist who these patients with TMJ no over-the-counter mouth guards because these patients already have a bit of a mechanical issue and connective tissue issue. They need special mouth guards. They just can't use anything generic. It might cause further damage. You can also take TMJ. So there you go. Risk huge. 85% of the people we all often we use our hands, and it's repetitive use and how much they have to do with their hands. And the feature some presentation of pain. Most of the other fingers have most ligamentous support, so it's one that takes the biggest hit when you elasticity. When you increase that elasticity, also a lot of pain in their forearms. It's also carpal tunnel syndrome. The issue that my patient brought up is the fact that every time she uses a pen, she finds it very difficult to again. Just like that, seen them have EDS, but these patients tend to grab it this way and they put a lot of pressure on the pen, and that's just even more. So normally, there are techniques that you can tell these patients if you come across them. That the treatments include fingerless impression glove. You have a home padded pen that you can use. Splitting is very useful. One thing, Although don't show off and try to sublux your fingers. $5 is not worth it. And this is what the Abel wear foam padding looks like. It helps them grab the pen. That's another very cool and allows hold it, use with any access on their tools. The thumb splinting looks like. It provides it enough support that you can use your hand. That's an example of the thing. The other part of the fire feet and ankles, as you can imagine, the elasticity and everything, you see suffer from a lot of flat, so that sort of really throws off the mechanics. Knee pain, hip pain, back pain, all of those are connected. The patient needs to see orthotics. They should try to walk barefoot as often as they can. They should do regular by raising ankles and toes. Taping. Taping seems to be the sort of the common theme for issues. And knee pain. So that's what ES knees can look like. So again, if you're looking like this, it's called stress. The mechanic way is quite mobile. As you know, there's a lot of momentous structures around the knee. A lot of them are quite lax. Once again, exercise, taping. So you can see in ways like to improve proprioception. Another interesting is action of the actually quite useful in with Danlos because the patient something called tachycardia, which is an autonomic dysfunction. Pretty much happens is that it tries from a standing position, the heart rate will just crank up, which actually is like a panic to people. Get all of that back up to where it needs to go. A huge problem. One of the first that a lot will end up dislocating. Shoulder end itself is a weak joint. There's a lot of decreased proprioception, so they go beyond where they need to. There's impingement, degenerative changes. A lot of these patients have huge with osteoporosis and arthritis. Around this shoulder, the neck always is a spasm picture trying to put a weak joint. Actually, if these patients are playing football or rugby, they dislocated back and forth and to younger people, it's cool. So they just pop it back and go their business. If current issues, it will cause problems. So once you get into proprioception, strengthen the muscles, swimming and contact sport, and take pressure. The neuro 60-70% issue people tissue have sheets around. Connective tissue is weak. These nerves are more susceptible to damage. So overstretch those alignments, joints. If joint pathway to go, you're going to stretch nerve and brachial plexus injuries, and complex regional pain syndromes are quite common. Something that a lot of us see on a better basis. So I'm not going to go into the treatment of it, but it is a huge problem with these patients. The problem is a lot of these patients require quite a few orthopedic surgeries, foot, ankle, knees, and a feature is very poor tissue. The healing is so poor that they'll go for these massive orthopedic surgeries, but they'll heal on you, and that's you can get a bit of CRP. So it can be a presenting feature of the Danlos as well. And everyone else knows medications. What role do they have? So the recent literature review from everything in 2017. Unfortunately, there's been no controlled trials or reviews to see what case work in Ehler Danlos syndrome. A lot of it's been, so you know what? Okay, neuropathic pain works for neuropathic pain. If you have knee joint pain, what that? So a lot of it's been extrapolated from other treatments that we use anyways. Said our journal not well tolerated in this. I mentioned initial gastrointestinal problems, a lot of dysautonomia. Patients not able to use NSAID, them very sick with it. Opioids have been found to be reasonable for kind of severe pain issues, post-surgical, sure, but no long-term pain management. In the sense, as you can imagine, with the sublux and movement they're providing this sort of constant stimulus of pain and tension. So the patients can get very high sensitive, sensitized, and on high opioids will over issue in these patients. One of the patients in Toronto that I was speaking to, 7,000 milligrams of morphine a day, went to the EDS clinic. Yeah, it does happen. It's not easy to treat. You're constantly damaging yourself on an ongoing basis. Neuropathic pain, sorry? 7,000. It wasn't me. Pain, no specific trials in EDS patients, very standard treatments that we use, gabapentins, TCAs, anticonvulsants. Better tolerated. It's right set. Good point. It's actually useful for all the spasms, nothing exciting. Now, no clear studies have done. Only the Toronto did mention that 80% of their patients are marijuana, and they prefer it way more than opioids. I know there may be some marijuana enthusiasts there or opponents. I won't open up to discussion. Marijuana will sort of look on as potential treatment strategy for these patients. Psychological impact. This is the third leg of the stool. So in my discussions, people that treat this illness, they go over the three-pronged strategy, the chronic pain, so sending to a clinic, the therapy part, which is extremely key. The third part that is also very neglected is the logical component of like what these patients are the ones with the hypermobile joints, young patients, see them as gymnasts, ballet dancers, functioning individual, hypermobile joints in the reach to their benefit and do things that other people can. And then the stage where now they've done too much, very real sense of loss. So two patients that I saw, very high functioning gymnasts, and both of them can't do it anymore. So there's a sense of loss, psychological component to this illness, apart from with a genetic disorder that has no cure. So it's one issue that is that a lot of it's dismissed, fibromyalgia, or you just have depression, hypochondriasis, malingering. I'm also in the comments there. And disorders are very high incidence. These people, 70% of these patients have some element of Indian panic. As I mentioned, the dysautonomia itself can be a panic attack. So in fact, that 41% of patients were on some kind of psychotropic or anxiety medications. Disorders that are associated with DS, so they're not to be confused. They have them. Different eating disorders, huge addiction, sleep disorders, attention and memory issues, especially for young kids. And one of the most common, even worse than is chronic fatigue. This sort of constant entrance, this constant fighting of your own life for keeping its shape really takes a toll on these patients. 80% of the patients suffer from chronic fatigue, and all the reports that the fatigue to be more concerning and taxing for them, even than pain. A lot of maladaptive behaviors with time, pain catastrophizing, fear of pain. One of the most important one is kinesiophobia, because one of the most recommended treatments is be careful. Don't do stuff that it hurts you. It's like being in a bubble, right? Don't go something, go do this, maybe you'll dislocate. So there's a real sense of kinesiophobia, which is even worse because you get sting even more. And one actually does have some evidence for this treatment. It is CBT. So Dr. Hapadou is pretty good on that, and mindfulness techniques. So mental health professionals can be involved, psychologists, child development issues, psychiatric nurses. This recommendations from the most recent task force support for. So what resources are available to us? You see someone you may or not know or think that as Ehler Danlos. So in February of 2016, after quite a advocating by 2 or 3 patients, Ehler Danlos suffering a lot. The government of Ontario finally put aside about $1 million to start an Ehler Danlos clinic exists at General Hospital, Chen, and finally in March of 2017. Currently, it's staffed by rheumatologists and therapists, and they're looking for people. And I spoke to the physiotherapist there, Leslie, so far about 75 cases that they're seeing across the right next to the sick kids. That's where we have the pediatric Ehler Danlos clinic as well. But this with Ehler Danlos, nothing. And this is a place where everyone in Ontario has been recommended to send any of your own institutional clinics no longer seeing Ehler Danlos patients. Mandated by the government is that you think that you may go to them. Quick referral form that's available from their What's important about Leslie is that coordinates care for people from all over Ontario. Other gaps she noticed was with physiotherapy component of the chronic management, and he even does to is that if the patient's part of their clinic and have their own private insurance or physiotherapist, she'll work with that physiotherapist, provide them with specific knowledge of this illness, give them all the resources, the usual courses to how to train all the interdisciplinary team members. So, if physiotherapist or OT or psychologist, and you have any questions about Ehler Danlos, you can costly ask for permission on behalf of McMaster. I'm more than happy to answer any questions. A good resource is actually physiotherapists available the general through the Arthritis Society. These physiotherapists tend to be a lot more knowledgeable about connective disorders. I call them as well. Yep, they be with this stuff more than other physiotherapists. So if you have questions, you go through Arthritis. There's in Burlington. And well, we have a neuromuscular clinic down on first floor. So I spoke to the nurses there. Yeah, I mentioned in March 2017, they're not seeing Ehler Danlos anymore. If you're goes Toronto, they have no other further resources to offer. There's no interdisciplinary team taking care of patients. So, on our own hospital, we're not dealing with this. As the minister wants it also to focus at one center, which can be for the better. Support groups available to these patients online. The ILC Foundation, actually a huge reason, EDS Canada Society, and I was browsing today. Just found there was a result in November of 2015, and because it was McMaster partnering up foundation hold this conference on Danlos syndrome. And what prompted this was ministry was getting a lot of requests from patients to go to these, to have a lot of surgical procedures that need to be done with these things, and the ministry finally realized that we're getting a lot of money, bring it away to the U.S. We should be doing it here. So this is part of this whole group that said that a lot of patients have aneurysms and cervicomedullary issues, and they want to do this here in Ontario efficiently in people's homes. There's still a lot of from April 2016. These things all around us. Frankly, I've been quite what's the word of this for a good medical career, but this is a huge lot of patients who have worst forms of Ehler Danlos really does take over their risk, and still work for done. So where I will leave you guys. Thank you.
We got 5 minutes for questions. Any questions? To me?
Sorry, I missed the two. No, I don't remember the two things that we did. Yeah. Did you, those are the only two things? So those are the I saw, and then repeat questions from remote. Sounds good. Thank you. So I think we both saw those two patients. I think you were able to follow up them or? So I called one, didn't pick up. One, she, what I've seen, how we're doing. So I was seeing a week program at St. Joe's, which is a therapy program involving psychologists and physiologists, patient pacing, doing very well. She's happy with the education and of affairs. So there's definitely a huge role for the psychological and the physiotherapy component of this, and that is the pre-treatment strategy. But there's a lot more out there. Rapidly. Life expectancy. Yeah, Dr. Happidus was if there's any difference between life expectancy of an Ehler Danlos patient with the general patient. I to be honest, I didn't look that up. But if I have to make an educated guess, they do have slight amount of issues all the way from cerebral endurance to cardiac issues. A lot of it really depends on the type of Danlos that you. If you use the type of classical or the mobile one, yes, life expectancy may be slightly less, but it's more the quality that's impacted. But if you have more severe forms, I will be very confident in saying that they don't live as long as the general population because of the comorbidity. Oh, sorry. Go ahead. Full turnkey operation all the way from this. It's one-stop shop, if I might say so, for Ehler Danlos. So new areas have to go through. It's as well at the clinic in Toronto. Yes, they are. Like I said, it's anywhere in that clinic. Yes. So pediatric is completely different from the adult one. So the clinic is only adult, and they want accepting the adult referrals. The sick pediatric one, I let it alone. I'm guessing. Sorry, are you right? So use your phones. That's good.
It's just from Roland Robertson. Just a general comment. Just a comment that appears to have a wait list already that is significant. 2 months or longer to call.
Well, I can see that Leslie's so trying to triaging in the referral, but from what told me, I'm sorry, should I comment? The comment that the ways for the EDS is already about 2 months even just get a call back. They are quite understaffed, more people, but they don't, like I said, they started 2 months ago. They still have, and frankly, if people are looking for a job, they're hiring big time. So I have nothing else.
Okay, ask Anne to come and to Association Chronic Pain Management.
And coming. So I'll talk about simulation training and chronic pain management with you. Mentioned that I was trained in Germany and Switzerland the last 6 years while in Hamilton. I spent the northwestern part, and this is just Germany and France. And also at the university. And here's the hospital. This is over here France, and there's Germany. And here's the Rhine.
You'd like to with the mouse, the online part as well.
Okay, sure, sorry. This is the Old Town, the University Hospital, over France. There's Germany, and here's the River Rhine. So that's where I lived. So I could walk to Germany or France. Where I know. And what I want to show is that the university is very close to mine. And after work, we take them on the road. The talk is about what you train, the different types of training which are out there, then specific simulation trainment and simulation for McMaster's pain program. So I was looking for some language simulation. And with you, it's specifically a grading tool, our cases. So we're trying to then that a student post patient process in the clinic and simulate the situation in the simulator. It's also to a complex situation. Sometimes the objective to be assessed in the clinic because of a lack of time, or just because it's for the patient supposed to the learner. And this their own patient simulate, they can get feedback, learn failure, and they can repeat as they want to. There's no risk of harming patients. They gain competence and confidence for the counter patient. It's very good for foster safety and error management. And this is probably because we, in the simulator, we give structured feedback about errors, about any error management. So trainees get used to talk about humans, and it's not too tough for humans. And because this is in the clinical practice, and they are reported. And last but not least, it's also an active way of learning. I have an analysis simulation-based learning to other learning tools. So the different types of skills were all put together, and zero line would be so zero means there is no effect at all of the T method. Simulation-based learning is favored, and on the other side, clinical education is favored. First 6 are randomized trials. And this the analysis shows that simulation-based learning is highly effective in learning skills. Of course, we all know learning skills are great to address with simulation, but studies specifically looked for skill in advanced support in surgery, auscultation, procedural placement of a central venous line. Then different type of simulation. There's the tougher, which means that someone can just procedural skills. The actors, which are also called standardization, and there are a computer-based simulation. Clinical situations. Is there any type of simulation training where you haven't been exposed to? Or have, because I think most of it probably supposed to, but it's tire you haven't been exposed to. Doesn't sound like. Oh, I haven't been exposed to any computer-based simulation. I recently got to know about this technique, but maybe your training was different in this perspective. Here's just some examples to realize what I just talked about. Here's an example of the task training. This is an example for computer-based simulation, or in the words, very intuitive case from the website of the University of Toronto. This is an example of our own simulation-based learning center, McMaster. You can see a situation where an actor and a student come together, and it's actor-based learning. And, the math-based simulation scenario, like you can see here, where the trainees are to a situation. And they can use the situation, but also practice the procedure skills of the mannequin. So simple type thing. So what about simulation pain medicine? I've been exposed to all of these tough learning within their training. So is type of simulation where you've been exposed to in this sense? Office. Okay. What about task training? Oh. Yeah. I have the same experience. I think medicine also been exposed to training, like sonography or do procedures or on a trainer, so-called trainer. This is called many examples in pain medicine. Then I was looking for some simulation, mannequin-based or standardized patient-based. Programs. And one program which uses simulation for pain medicine and learning is pain medicine recertification program of the American Board of Anesthesiology. So, if you're a patient who want to be certified, you need to do some training on mannequin or a standardized patient at least every years. And the second example I found was some use of a standardized patient pain medicine and palliative care residency program in Ottawa. So they are as well. I'm aware of more where just the patients some pain. Okay, so going into more, there's a whole bunch of scenarios which is used for the certification of pain medicine in America. Let's read through it because it's written. So one example would be a convulsion after given IV local anesthetic, or a respiratory arrest after filling an intrathecal. after methadone medication syndrome in a patient opioid bicyclic, intensive emergency after doing a cervical epidural speed injection, a pneumonia, for example, an intercostal nerve block, or high tension after celiac plaque fluctuations with a PEG tumor or whatever. And the other examples here. Would say that all really applications of pain treatment. And, the skills addressed include, like you can see on the bottom line, teamwork, communication, leadership, resource, skills. This is quite from what the University in Ottawa has done. They developed scenarios for their program. One is the opioid initiation, and the other one was a failed OP trial and meet a difficult patient. That are quite common situations on our clinics. We have sometimes difficult patients, and we do opioid initiation and failed opioid trials quite regularly. So the question is, I practice those scenarios in simulation setting or versus the clinical settings. If we are seeing those scenarios anyway in the clinical settings and are just trained in the clinics. Any suggestions or any ideas on that? Any thoughts? Well, develop those scenarios. How how can be the simulation setting then superior to the clinical training? Why is it better to train those in the simulation compared to in clinic?
Oh, I'm not saying that one's better than the other, but I think to do simulation because obviously the setting is wrapping at least you can get some skill sets and then you can apply those kind of things. So you see so often it's worth trying to do
Yeah, I totally agree. I had the same thoughts actually. I feel in clinics we just sometimes don't have enough time to get back about communication skills, and I really observed in doing those things. So I share your impressions. I have the same thoughts. All pretty useful scenarios as well. They are common and quite different from the ones we use. I'd like to end with simulation training at the university, specific in pain medicine. As a fact, I was exposed to some simulation training during my fellowship in chronic pain. One was training sound for nerve blocks with Mauricio Ferrero, and the fast training in graphically pain procedures with Joseph Parks. And both sessions really great, and I really appreciated that type of learning. I am aware of one pain center, which is McMaster, but the pain fellows, but Anesthesia, and about an instance of local anesthetic toxicity. It's a simulation. and I think really useful for the pain fellowship as well. Like just mentioned before, we had a new project at the university training, and we put together a little group who applied for implementation in pain residency and fellowship. Other reasons I just talked about before. Center McMaster gives the opportunity to develop even some men-based or egg-based relations. Are you familiar with the people out of the group? Probably. I go with the project, and what we want to is first we would like to find our project first at university, then also in other pain centers in Canada. And we would survey the pain fellows and pain leaders, as well as the directors of the pain programs, to see what they think would be great scenarios to develop. And if that would be an option for them to add to their curriculum as well. We would, if they have any resources for developing scenarios as well, and maybe do that together with us, other scenarios then. After these, we would develop them at McMaster and test at the nurse shop and then implement them at the McMaster University, the residence and fellowship. And repetitively evaluate for educational goals and refine the scenarios and the whole program. Thank you for listening.
Any other questions for Anne?
Similar training has been used in writing areas. Many years ago, when my pilot's license simulators were far advanced in terms of training as well as doing cracks. That's a big emergency medicine. I saw some simulators for trained physicians that they're not putting it too late and giving those the drug. It would be able to sense it. But in each case, they have to define of what they're going to simulate. So what we're going to do is for the next years. What do you hope to accomplish? Because it's about the Ottawa for opioid starting and stopping. I'm not so sure that station is the most appropriate user station for that particular case. You can do that for practice learning of everything. So in a fellowship program, the evaluators, you touch on it earlier of risk complications recognized. So what do you say at the end of your 2-year fellowship? What do you hope to be able to use to train for, even if it's just what do you say they are?
So the question would be the most useful object training, not to waste any resource, because it's expensive, it's a lot for developed scenarios, and and we can't use it for everything. Even we maybe, but it's the ability to actually the probably. I think the list I went over with you before, American War, about all the complications of seizures, agree develop those. Those would be really helpful things to address. It's so rare in the clinic that we can't really be trained on those. But after it happens, we have to be prepared. So I think all varieties after anesthesia we see with procedures to be prepared for them, can't prepare in the clinical setting and doing there. And I see is using those objects emergency in pain medicine would be that we could train the team. We could establish culture. We are prepared for such emergencies. Of the team who was in the simulating of the situation was okay in my clinic. Where's the MBX to manage a respiratory arrest? Where are drugs for the lipids for managing IV intoxication of life? Everyone would get more aware of this complication, and the community within the team would also improve if the whole team would together in a simulate those topics. So I think all emergency cases have really great potential.
If I may interject, I'm sorry. From the college perspective, these types of scenarios are difficult because a trainee counseling someone about opiates or opiate trials may not always happen when you're ready to evaluate someone. And having a setting, watching some county in a standardized scenario may be certain improvement on sort of the haphazardly that can happen in real clinical scenarios. So even if it could be done better or less costly way through all the discussions, having watched someone interact with a standardized patient, for example, in a static scenario would give us evaluators an objective way of seeing how well someone's doing and tracking progress on that. Is there any way you could summarize that maybe?
Philip just answered the question of Dr. Reyes regarding the most scenarios and which to choose, and added that it might be difficult to track if students are really well prepared for complex initiation of an opioid or failed opioid trial and delusion. So it had safety to check regularly if those situations are matched well, and test those tasks in a patient and help students to improve. Every time have been tested for those, will get a feedback, and Tom can incorporate this feedback to his practice and gets re-evaluated, and this allows us to guarantee that the standard of care is optimal. Did this mean what you were saying? Okay.
we applied for the grant, I know there was I didn't know the outcome was because we have it. I think the next person we have it.
Was for Hausha Shantana if we got it, and yes, we did. So it was approved, and and we are supported for 2 years. Of this project.
Excellent presentation. I'm certainly looking forward to this simulation chronic pain. It's really needed, and there's certain values, especially from interventional pain. We have been thinking about this for the last many years. So glad that you initiated it. Thank you very much. Okay, this will conclude our main round by two excellent pain fellows. Thank you very much.